Hello and welcome to this evening's mid-year 2022 Functional GI Trends webinar. On behalf of our host, Commonwealth Diagnostics International and My Total Health, we are very excited to have our discussion and Q&A on timely themes and new research impacting the GI community. CDI's mission is to help providers better identify and diagnose common sources of digestive distress and functional GI illness, with a focus on developing a portfolio of non-invasive and cost-effective diagnostic tools that result in expedited treatment, better patient outcomes, and robust cost savings for the healthcare delivery system. My Total Health, which is powered by its My GI Health platform and data aggregation technology, provides GI-focused industry solutions, including patient-provider engagement tools for GI practices, patient-driven marketing and sales solutions for healthcare brands, and subject recruitment and enrollment services for academic researchers, industry sponsors, and GI clinicians alike. Just a little housekeeping before we get started. Today's panel discussion is being recorded and will be available to the GI community following today's event. If you have any questions during the panel discussion, please feel free to type them into the chat box in your Zoom control panel. And we'll try to cover as many questions as possible during this discussion and our rapid fire Q&A at the end. Now, without further ado, I'd like to introduce our industry moderators for tonight's panel. Dr. Brennan Spiegel is the Director of Health Services Research for Cedars-Sinai Health System and founding director of the Cedars-Sinai Master's Degree Program in Health Delivery Science. He also serves as Cedars-Sinai Site Director for the Clinical and Translational Science Institute and is an Assistant Dean for the David Geffen School of Medicine at UCLA. And Craig Strasnick is a seasoned executive experienced entrepreneur and dynamic commercial leader. He currently serves as president and CEO of CDI and is a board member for Functional Gut Diagnostics, a CDI joint venture in the UK, My Total Health, developer of the My GI Health platform, and GI Logic, creator of ABSATS, a non-invasive biosensor device. Dr. Spiegel, Craig, it's great to have you here today.
Great, thanks. Thanks so much, Jason. I, for one, am excited for this discussion tonight. I appreciate the work that you put into it. I think coming out of DDW specifically, we have a lot of really fascinating areas to dig into. So thank you to all of our panelists and to you, Brennan, for moderating this event alongside me. I appreciate it. I have the pleasure of introducing our first panelist, Dr. Andrea Shin. Dr. Shin is a practicing gastroenterologist and assistant professor of medicine at Indiana University in Indianapolis within the Division of Gastroenterology and Hepatology. And she has a special interest in disorders of gut-brain interaction and gastrointestinal motility.
Thanks, Craig. And I'll introduce our second panelist, Dr. Hetal Karsan, who is a clinical gastroenterologist and also a friend. We trained together actually as GI fellows many years ago at UCLA. He's a partner at Atlanta Gastro Associates, and he serves on the executive committee for United Digestive and oversees medical education there. He's also an adjunct professor of medicine in the Division of Diseases at Emory University School of Medicine, Digestive Diseases at Emory, and also co-author of the Acing the GI Boards series of books. So thanks, Dr. Karsan, for being with us.
Thanks for having me.
Absolutely. And next, Dr. Anthony Hobson. First, I just want to especially thank Dr. Hobson for joining us in the middle of the night from the UK. We're especially grateful to him and his family, most likely, for that and for being here. Dr. Hobson is an internationally renowned clinical GI scientist, and he currently acts as the clinical director and senior clinical scientist at the Functional Gut Clinic in the United Kingdom. He's also the co-founder and director of Functional Gut Diagnostics in the UK.
Hey guys, thanks for asking me.
Yeah, thank you, Dr. Hobson. So today we're going to talk with our panel about sort of the reaction and response from Digestive Disease Week, DDW 2022. This was a very exciting event. Not sure how many of our listeners were able to attend, but this was the first time we have all been together as a GI community for a few years. So it's really exciting just to get back, see one another, and here's some outstanding science. And today we'll kind of touch on some of the topics that came up at DDW that we think are especially relevant to practicing gastroenterologists particularly with a focus on functional GI disorders or disorders of gut-brain interaction. Now, prior to DDW, I did myself a preview of DDW with Dr. Leen Charabadi with Medscape, and that was posted, and I can put links to that later, that sort of discussed our expectations for the spring meeting. And we had lots of exciting discussions about IBS and new medications, new devices, new behavioral interventions that are now becoming available for functional GI disorders, and also new research on the role of the microbiome in functional GI disorders, a very important, exciting area of research and discovery. And of course, DDW really did not disappoint. So now we're really excited to kind of break down some of these topics with our esteemed panel today. So I'll hand it over, Craig, to you, and you can get us started.
Thank you, Brennan. I appreciate that. I think you hit the nail on the head. And Dr. Shin, if it's okay, I think I'd like to start with you. I just working off of the points that Brennan was making. I am a firm believer in just the direction overall that medicine is headed, taking a more personalized, precision-based approach to some of these trickier conditions. And you've done a lot of research. You've been a major contributor to studies looking at the pathophysiology of IBS, specifically helping characterize and subsegment IBS patients, but more generally functional, or to Brennan's point, again, these DGBI patients. This is, of course, a tremendously challenging patient population. It's an estimated 40% of the global population that are afflicted with one of these conditions, yet there's so much heterogeneity embedded in this category. Many times it needs to be looked at in a very personalized and precision-based way, almost on a case-by-case basis. So I'm just wondering if you could start maybe by giving us some general updates around your field of interest and some of the significance around your research in this category.
Sure. Yeah, I'm happy to. Thanks for having me here today and inviting me to kind of discuss on some of these topics. Like you mentioned, Craig, I kind of see myself as part of a community of researchers that, investigates pathophysiological mechanisms in IBS. And part of the reason that we do this, obviously, is not only to try to better understand the disorder, but I think that most of us kind of see it as a pathway for the development of novel biomarkers, either for enhancing evaluation or developing more specific therapies for these disorders. A lot of the therapies that we have for IBS and other similar conditions within that spectrum are already based off of our framework of a conceptual understanding of pathophysiology. But I think we still have some significant gaps in terms of how we can translate that knowledge into usable tools that are widely applicable in a clinical setting. So that's kind of the motivating factor for the work that we do, for our team, and then just as our community. More specifically, part of the research that our lab focuses on is studying the role of the gut metabolome and the gut microbiome in irritable bowel syndrome specifically. That's kind of our model for how we're trying to describe microbial functions within the gut. We focus specifically on certain metabolites like short chain fatty acids because we know they're so integral to normal healthy gut function. And some of the more interesting findings that we've shared recently in other platforms and at DDW are the fact that short chain fatty acids that are excreted are very measurable, and they do correlate very tightly with gut physiology. But how we use this knowledge for patients with irritable bowel syndrome is still a developing area. We've previously shown that short chain fatty acids, which are microbial metabolites, correlate with things like transit and gut function. But more recently, we've also had some recent work that suggested that these metabolites are also probably involved in mediating the gut-brain crosstalk as well. Some of these metabolites like acetate and butyrate were actually found to be linked to mood and anxiety in individuals with IBS. And so I think that this is, continuing to expand our interest in this topic and how we might specifically study the functions of the microbiota in terms of how they influence symptom severity and, what we call a phenotype for an individual and how we might target that for, developing new personalized therapies for people down the road.
Fascinating. And I wonder too, just as a quick follow-up here, it sounds like this is, some early stage research, but there's also some early indicators of success. And I'm just wondering if you see any products or if there's any companies out there that are, kind of working to bring technologies to the clinic that can help to clarify or answer some of the questions that you're starting to hash out early in your research. I know I think it was, I want to say it was in gastrointestinal maybe, but there was some data that came out that showed just psychological distress can precede the onset of IBS and be aggravated by the challenges of managing those symptoms. That I think it was somewhere between 30 and 90% of patients with IBS have severe symptoms that are comorbid to psychiatric conditions. So I guess I'm wondering, Dr. Shin, ultimately, how you kind of manage disorders of the gut-brain interaction in general, and if there's a place that you start, if it's kind of research based and you are taking it on case-by-case basis, depending on patient histories, treatment history, comorbidities, wherever the case may be, or if there's a more standardized approach that you're using right now in clinic until some of this early stage research becomes a little bit more validated, a little bit ready for prime time, if you will.
Yeah, no, that's a really great question. I think in terms of how we approach patients, a lot of it is based on our current grasp of the evolving research landscape, even though we may not have a standard algorithm that we apply for individuals, routinely. I think what you brought up in terms of psychological comorbidities or even prior history of trauma or early life stress, all of those things can be factors. And so that's one of the reasons that, for example, really detailed history taking is so important when we see these patients in the clinic, to try and tease out what features of their personal life experience might be predominant contributors, because that information does help guide the approach that we take. So, for example, in someone who does have bigger contributions from, psychological stressors, you may be more likely to direct them towards a path that could involve psychological therapies, including cognitive behavioral therapy or even hypnotherapy if you have those treatments available, or the use of, neuromodulators. While someone who is in a different spectrum of the disorder, who seems to have less of those contributors, but perhaps more of a peripherally based disorder, then in that case, you might tailor your treatment strategy to offer something that may be more gut specific, whether it's diet-based approach or the use of certain pharmacologic agents, depending on the predominating symptoms that they're experiencing. So there's a framework, but it's not the same pathway for every person.
Not one size fits all. No, that's really helpful. I appreciate that. I think I wasn't necessarily trying to, but I think a really good segue into a follow-up question. And Dr. Hobson, maybe I'll turn this one over to you if you don't mind. I know you actually gave a talk in this area recently, and just generally about the tertiary care pathway for digestive health. And I'm wondering if maybe you can just explain a little bit over the top just what TCP is, and then the significance for these functional or DGBI patients, and how you see it kind of playing in the clinic now and a future role as some of these technologies progress, and this idea again starts to take main stage a little bit further.
So I think the tertiary care pathway talk was kind of a little bit of a red herring, in the fact that at the end of the talk, the conclusion was that actually digestive health shouldn't be in tertiary care where it is at the moment. It should be in primary care, or primary care 0.5, because patients present with a lot of unexplained symptoms and they go through all these unnecessary investigations, and actually they could be dealt with much earlier in the pathway, a much more cost-effective way if we have better diagnostics and better screening tools. It's strange that they, a patient with IBS will end up having thousands of dollars worth of investigations before actually being told that there's a fairly simple solution to it. So in terms of the omics, for me, I always kind of eye roll a little bit because I haven't been in research for 30 years. There's been this black hole of genomics, proteomics, metabolomics, and it's kind of sucked away all of the research funding, and very little of that has translated back to the clinical coalface as it was into how we translate that into clinical practice. But I think that's changing slightly, and I think the microbiome is a great example of that. When I was doing my IBS research for my PhD and collaborating with people at UCLA and looking at brain imaging and looking at the kind of, the functional consequence of brain activation, we weren't really thinking about the lumen. But actually now, thanks to all the work that's gone on in the last, especially 10 or 15 years, we're now realizing the microbiome is pivotal. But the microbiome research that has been undertaken has been mainly done with stool samples taken from the back end of the colon. And I think the research that excites me is, being able to collect stool samples from different parts of the colon using things like colonic irrigation, where you can get a cecal flush and look at what the microbiome is doing in the proximal colon compared to the distal colon, because it's completely different. And that's probably where most of the action is going on. But then also, looking at how we can stimulate the microbiome with carbohydrate probes and other probes to try and look at the functional consequence of what differences in the microbiome does. Our own research now is looking at how we can look at different breath biomarkers that are functional consequences of microbial activity. And there are thousands of compounds, volatile organic compounds, short-chain fatty acids, gases that you can measure in breath that are metabolic markers of microbiome activity. And I think that's the really exciting area for me, is how we can both look at how things are at baseline, how we can manipulate those biomarkers with diet, with pharmaceuticals, and really try and develop new models to see how the changing the microbiome and changing the metabolic profile of the microbiome will aid clinical benefit in the future. So I think we're on the precipice of a fantastic new era of non-invasive biomarkers for microbiome activity.
It is fantastic and it's exciting. I agree completely. I have a quick follow-up before I turn it back over to Dr. Spiegel. Dr. Hobson, do you see kind of this model pairing with what I believe is kind of a paradigm shift that's here to stay, one that was from kind of a historical fee-for-service to this new value-based care model and things like remote patient monitoring, chronic care management, I think are going to be a necessary component of managing these patient cases overall. But that's not to say that having the patient present for specialized procedures to ensure that you have a very robust set of data to make an informed decision, but then continually monitor these patients, at least in my opinion, is going to be a tremendously important aspect of all of this. If you wouldn't mind just maybe giving a quick follow-up of how you see kind of both working together in tandem to be able to most effectively treat these patients moving forward.
So I think the most important part of that is the triage process. So when a patient enters the system, is to make sure that you're not kind of missing anything. And by not missing anything doesn't mean over-investigating people. It's developing algorithms where you can screen patients coming into the system and saying, right, okay, we're pretty confident this patient hasn't got something serious going on. And if that happens, then you can put them down a pathway where you can start to do longitudinal assessments. And whether that is treating them, so you could do a breath test and see if they've got SIBO, you can treat that and then you can monitor that over time. And with some of the new devices and apps that are available, you can track symptoms over time, you can track gas profiles over time, you can track all sorts of different things. And then when a patient starts going to a point where they go from being in a kind of remission phase, if you like, to potentially flare phase, then the healthcare professional can intervene to stop it becoming a full-blown flare. So I think that is where the future is going. That you might get patients who enter the system either in a flare state who need treatment acutely, but then it's how you keep them, keep their symptoms at bay, keep them in that kind of remission phase where their symptoms don't flare up again, and actually get them back to a healthy microbiome. Because let's face it, I mean, most people who develop these symptoms have had some kind of intervention, whether it's an antibiotic intervention or it's a stressful life event that's caused this kind of chaos. And what you want to do is bring them back into order, whether you can do that with medication or you can do that with diet, or you can do that with psychological therapy. Once you've got them back onto an even keel for a healthcare professional and the patient, you want to be able to monitor that and make sure that they, like you would do with blood pressure or diabetes, you want to keep them in that kind of remission phase and stop it becoming an issue again. I think that's where the future lies for us.
So important. No, thank you for those insights. I appreciate it. Dr. Spiegel, please. Mike is yours.
Absolutely. Well, thank you, Craig, and thank you for that discussion. I've been enjoying listening to that. And I think there's a few key points so far. I mean, the first is trying to understand the idea of biomarkers a bit more. There are still limited biomarkers that we use in everyday clinical practice. You know, breath testing is one example. There are many others, but not that many others that we can really rely upon clinically and that will change clinical decision-making. So I think more and more it's going to be vital that we think about this. There are certain things that I think we sometimes take for granted that we could look for. So for example, we've been talking about the microbiome, talking bacterial overgrowth, and one of course has to ask, well, why is there bacterial overgrowth in the first place? Like, what is the prime cause of that? What led to that? And so often we think, well, there's some kind of dysmotility, for example, or there's some kind of disruption in the functional status of the gut. So we call it a functional GI disorder, even though it's not a perfect term. And so one asks, well, why is there dysfunction in the gut in the first place? You know, and so there are interesting phenomena that we see in IBS. Some people with IBS have hypermobile joints, for example. That's a biomarker. We don't test for it very often. Why is that? Well, we know something like Ehlers-Danlos syndrome, which is pretty rare, but there are more and more cases we're seeing of people that actually have a flexible mesentery, and that could lead to abnormalities in flow and function of the gut. And we can actually check for these kinds of things in the clinic by just looking at joint mobility. That's just one of many examples, and there are so many more. If we had time, we can go through a whole list of conditions that can also sometimes mimic IBS, and that we can, I think, do a much better job of looking for. So that's more of an aside that maybe would be another seminar for another day. But as we kind of move and pivot towards the clinic, which is what my transition is here, I want to ask Dr. Karsan a little bit about a very practical area, which is diet therapy. And we know that diet can, of course, affect the microbiome. It can affect intestinal transit and fluid dynamics in the gut. So Dr. Karsan, you're a practicing gastroenterologist, spend all day and night thinking about GI, hopefully. And so tell us about, your approach to diet therapy just in your practice.
Well, thanks for asking. First of all, honored to be here with these esteemed colleagues, and including Dr. Shin, Dr. Spiegel, Dr. Hobson, who's celebrating the 70th anniversary of the Queen on the throne today. But I would like to, I'm in clinic all day, or some days all day, which may or may not be my favorite day. But nonetheless, I do not check for joint hypermobility, I must say. But I do use dietary therapy. I think there's a lot to be said about diet. And at DDW, there were a number of abstracts just on dietary therapy alone and what diet does in regards to IBS. So I do think patients love to hear about diet and how they can help themselves without the use of chemicals or drugs, so to speak. And I often go with a low FODMAP diet and explain this to them. And time is limited in the clinic, so I definitely advocate for the use of a dietitian, which we use in practice. And she sits down and goes over all these dietary changes that patients can make to avoid gas-producing foods. And sometimes that'll help quite a bit. And then generally and gradually reintroduce them after, let's say, a month or two. You don't want these patients to lose a lot of weight. Sometimes these low FODMAP diets are low calorie diets too, and they can lose a lot of weight. So a dietitian can help monitor that and keep track of patients as well. So I do think there's a lot to be said about diet. A lot of these studies, they're tough to control for diet. We're not doing studies on prisoners, and that's not ethical so it's hard to keep diet uniform and controlled in a lot of these studies. But I do think diet is a key, and that is probably at least part of the wave of the future for IBS, among other theories that are coming out.
Mm-hmm. So in terms of other kind of pragmatic advice, maybe non-pharmacological, some people recommend, let's say, exercise, Tai Chi,
Exercise for sure. I say at least half hour of exercise, 3 to 5 days per week. And there's actually been some controlled studies that seem to show some benefit with exercise and IBS. So I do think general well-being, it helps. And it probably is some portion of anxiety that helps. Reducing anxiety with exercise will certainly help. So yes, that's a big form of therapy as well.
Yeah, if you think about it, we're carrying around this GI tract in our belly. We're destined to a lifetime of carrying around a huge sack of salt, basically, in our belly. A huge percentage of our body weight is contained in the abdominal cavity. And so we have this superstructure that has formed around it to carry and hoist that thing throughout our lives. And it starts with the axial spine and the rib cage and the diaphragm and the falciform ligament and the mesentery and all these interlocking interposed connective tissue systems derived from the mesoderm that are there to help support and move that sack of salt all over the place. And some people are formed in a better way than others. Some people have low back issues, they have paraspinal weakness, they have anterabdominal wall weakness. And just getting to the basic principles, exercise can help strengthen the core muscles that are literally there to support and hoist and suspend the intra-abdominal contents. And, what do we see with people with scoliosis? They get IBS. What do we see people with lordosis? They get IBS because you're changing the morphology and literally crunching the structure in the abdominal cavity, which secondarily leads to aperistalsis, or at least diminished, not aperistalsis, but diminished transit, diminished flow, kinking, secondary bacterial overgrowth, and so on and so forth. So I think just going to first principles, right? We need to physically protect and suspend, the suspension systems in our abdominal cavity. And I think that often is never discussed, and it's not hard to understand. And it's something we can do a lot more work with our patients.
Just to interject here, I think yoga has been shown to be quite helpful. And I think that goes with core strengthening and flexibility. So yoga as well as exercise, I think, is another part of the cusp of the future.
So let's switch gears a little bit as we continue our discussion here. And for those of you that are listening in, feel free, if you have a question for the panelists, I think you can put it in the chat, I believe. And so we'll look for that and answer questions that come up. So in previous versions of this webinar, we've always had sort of general discussions on some of the new digital therapeutics and new technology advancements that we're seeing, some kind of far out there, but some are actually really close at this point for managing people with functional GI disorders. That's our topic today, and GI conditions in general. So I'd love to go around and get your take on maybe different products or technologies that you might be keeping an eye on or kind of monitoring the data, including recently at DDW. And as I said, some of these are already in practice, some of them may be future ideas. And if you don't mind, I'm just going to start, actually not with my favorite technology, which I might talk about later, but with a technology that I saw at DDW that actually made a pretty big splash. And I'm sorry if I'm stealing anyone's idea, but I didn't hear in advance what you guys were going to talk about, but it's this vibrating capsule. And so some of you may have heard about this. There's a company in Israel that created this, this capsule that's actually going through FDA right now. And it's very unusual because it's a pill, but it has absolutely no pharmacological effect whatsoever. It doesn't open up. It's just a piece of plastic. You swallow it, and 8 hours later, it starts to vibrate. Apparently, patients don't feel it too much, according to the data presented at DDW this year. But in a randomized controlled trial of the capsule not vibrating versus vibrating in a very particular sequence in the colon, it seems, or at least it's hypothesized, to kind of kickstart peristalsis, although it's really a little unclear just how it's working, and has improved complete spontaneous bowel movements in a randomized trial. So I'm kind of interested in this. It comes literally in a blister pack. You pop these things out, you swallow them, and they pass through and you poop them out. So I think that's something I've been interested in looking at. But Dr. Shin, have you seen anything that catches your attention?
I'm glad that you brought up that capsule. I thought that was really fascinating as well. And I think that we'll probably see more data on that to come. I think it has a lot of promise. One of the other, I guess, digital technologies that I thought was maybe of interest at this year's conference was, I think there was a study on an app-based program for treatment of IBS. And it was actually basically a self-driven program, but guided by this application, and patients were randomized to receive guidance on either, diet-based therapies or psychotherapy using this app. And at least from this initial study, it seems that patients improved with the program. And part of the reason I thought that was quite interesting is that oftentimes I've felt that a lot of people who are struggling with these chronic disorders could really benefit from more engaged coaching sometimes. And oftentimes, they might rely on, their clinician or their doctor to fill that role, but, with limited time and perhaps with demands in terms of, how often they're able to meet with their clinician, that guidance is often lacking. And so an app-based program like that really has the potential to fill in some gaps. So I thought that was really fascinating and might be something that we might hear about more in the future as well.
Yeah, that's a great example, and I'll hear from the others in a moment, but I just want to interject for a second. Cognitive behavioral therapy and other behavioral therapies are well established, right, to improve the symptoms of IBS. We've touched on this a little bit today. And so, there's a lot of theories about why that is. And, we always talk about there's some patients that are a little more brain than gut, and some others are maybe more gut than brain. What do we really mean by that? Well, some people literally talk about the mechanical systems I just mentioned earlier, are literally constructed to manage their gut load in a way more effectively than others. But it certainly gets stressful if you're getting dragged down all the time. And so we know for sure that if we tamp down hypervigilance, so this is really the idea of kind of gut protection versus preventing threats that are coming. And so that's the idea about this hypervigilance, is this ever-present concern that a sort of a gut punch is coming at you, so evolutionarily speaking. And so it's clearly effective to both improve your physical constitution through exercise, Tai Chi, obviously to alter the luminal constituents in the form of antibiotics and probiotics and the diets that we use, but also to change the way the brain is experiencing those loads and those sort of afferent signals through cognitive behavioral therapy. We know that the brain is not a block of Play-Doh sitting in the head that's just sort of haplessly sitting there. It's a shape-shifting organ like any other organ in the body. We can change it, we can modify it, and there's overwhelming evidence that cognitive behavioral therapy and other forms of psychological therapy absolutely do change the structure and the function of the brain in a way that can improve GI symptoms, tamp down hypervigilance, and improve quality of life. So I think things like apps, and my other favorite technology is virtual reality. So we've been developing IBS VR, which is a new treatment that's very much like what you just described, but in virtual reality. You can maybe talk about that more some other time or later if there's an interest. Dr. Hobson, what have you been watching? Anything catch your eye lately?
Well, first, Brennan, just to say about EDS patients, it's something we look for all the time, and it's really simple. Do you feel dizzy when you stand up quickly? Do you bruise easily? Are your joints a bit clicky? And these patients have often been to a rheumatologist, they've been to a urologist, they've been to a gastroenterologist, and the problems are that people don't look at them holistically. So literally, just by asking a few simple questions, you can then take them out of the system and make sure that people aren't treating them inappropriately and treat them holistically and sort those problems out. And they're about 20% of our practice. So 20% of patients that refer to us will have some kind of, they'll be on the EDS spectrum. So really important to pick that one up. In terms of wellness devices, I think the danger that I see with these is that if they're marketed as a kind of wellness device and not a medical device, then they can be used unsupervised in the wild, and people will be making semi-medical decisions about, dietary restriction based on devices that without the support of a healthcare professional. So I think that devices and apps will be really crucial to the future, but they have to be under the supervision of some kind of healthcare professional, because otherwise, as we know in IBS, people already have a fear of eating and can develop into eating disorders and be, excluding things from their diets, which are completely fine for them, but they've made a decision based on an irrational choice. So I think it's really important that as these devices are developed, they're done through proper clinical trials, proper clinical supervision. And I think as things like AI and virtual reality and things develop, then you could probably take relax a little bit about it, because the algorithms will be a bit more supportive. But I think in this initial stage, people really need to do the validation work. And I think that's across the sector. I mean, if you look in the States now, I think it's $36 billion spent on supplements and probiotics and prebiotics. And how many clinical trials have you seen that are good quality compared to the pharmaceutical industry? And yet people are popping these things all the time, and they may be good, bad, or indifferent to them. So, I think the whole digestive health world, is not life-threatening for many people, but it really needs a level of governance over it to make sure that we don't, allow people to go down rabbit holes. I think the most exciting technology that I've seen that was presented at DDW, there's two aspects. It's this reinvention of looking at motility via either magnetic resonance imaging. There's a company called Motilent that are looking at the way that the bowel contracts and imaging to look at that in real time. At the moment, it's not access for everyone, but I mean, the implications of being able to look at gastric emptying, colonic emptying, in real time, especially in upright scanners, is fantastic. And the other thing was high resolution electrogastrography from a company called it's a New Zealand company that have created an array of electrodes that you kind of stick onto the abdomen, and then you can do a food challenge, and you can look at, just like you would do an exercise ECG, you could do an exercise EGG and look at how the stomach propels food through the system and looks at the neurology and the causes of things. So I think there's never been a more exciting time of functional GI diagnostics. I think the integration of the technology with the apps and the artificial intelligence is going to revolutionize the way we look at patients.
Terrific, great examples. Dr. Karsan, had any technologies catch your attention lately?
This vibrating capsule is kind of interesting. I just don't know how that works, and it seems kind of interesting if there's any real sensation or as it travels through, but that is something kind of interesting that, that might be, it completely caught me off guard. I had not heard of anything like that. So I think that was kind of interesting. But yeah. DDW was just a lot of stuff out there. And it was nice to see the research coming together.
So I guess it's all about calling the wheat from the chaff, and discussions like this can help us get in that direction. So why don't I kick it back over to Craig and to continue our discussion.
No, thank you, Dr. Spiegel. I think I just learned a lot. I found that to be tremendously fascinating. I actually have never really heard it explained that way as you just did. I mean, it seems like a practical application: workout, exercise, do the right thing, stretch, yoga, etc., to just keep yourself healthy, and that should in turn make your digestive distress at least reduce. But to actually think about it and hear it explained biologically was very, very helpful. And all of these technologies, I think, to help monitor these patients in an ongoing fashion is going to be tremendously helpful. The question I wanted to go to next was really not necessarily technology or product driven, but more just kind of state of GI at large driven, if you will. There was some data that just came out recently in a really fascinating study by Dr. Laurie Kiefer and her team at Northwestern that illustrated kind of a growing need for just continuing education in general as it relates to GI trainees, specifically their attitudes and management toward and with patients with DGBIs. It specifically found that patients with these disorders are still inadequately treated in a lot of circumstances. They face stigmas that can adversely impact their course of treatment. And even just more broadly than that, and I guess more anecdotally than that, I was recently sitting in a meeting with some other industry leaders in the leadership of ACG, and there was a statistic that I heard that was shocking me, which was that just application for GI fellowship in general was down fairly dramatically. I think it was 10, 11%, something like that. So I'm wondering, to that end, what insights maybe any of the panelists have into how to potentially begin unwinding that stigma for these patients, and finding better ways to utilize information to get to the root cause and hopefully increase quality of life in a far more expeditious way than they have been in the past, and how to further get GI trainees to gain awareness and additional training on these disorders and how to better manage them, because they're chronic conditions, and these are patients that ultimately they're going to end up hopefully developing relationships with, that maybe unfortunately will be long term, but if they can figure out a way to keep those patients healthy along the way as best they can, that's tremendously important, and taking it seriously is just as important. I guess Dr. Hobson, I'll start with you. Sorry, I guess I didn't name a panelist there. My apologies.
So I think we touched on this a little bit earlier, that the amount of patients out there is vast, and the training, certainly in the UK, is incredibly poor. So I sit on the Association of GI Physiologists committee, and there's about 120 of us in the whole of the UK, serving a population of 60 million. And the Neurogastro committee of the British Society is pretty small as well, and they don't even have a specific part of their training curriculum for functional GI disorders. So they have all the other aspects of gastroenterology, and then there's like a throwaway week or so course that they do for functional disorders, even though it's 40 to 50% of the patients they will see. So it really is terribly poor, and even in primary care. So as I kind of said in the presentation you alluded to, Craig, we need a revolution in how these patients are assessed, and I think almost it needs to shift the whole patient pathway backwards a little bit, so that when patients present in primary care, then they have a whole armory of tests and diagnostics, once the red flags have been ruled out, that are addressed at that stage before they escalate and over medicalize further down the line. One of the shocking statistics that we heard recently from a paper that Alex Ford did in the UK was that patients were prepared to, if they were asked hypothetically to give up years of life for a cure for their IBS, they would be prepared to do that. That's how desperate these people are. So they're not life-threatening conditions, but they affect people absolutely desperately, and they would sacrifice years of existence for a cure for this. So I think what we need to do is to, as we've talked about, increase our understanding. But I think the whole pathway needs to shift to the left a little bit, and more needs to be done in that kind of self-help primary care pathway, early secondary care pathway, before you escalate up to over medicalizing the condition. And I think the danger for a lot of patients is they get into the system, they have repeated colonoscopy treatments, sometimes they have inappropriate surgeries and things like that. I think if we can try and educate people in the early pathway, I think that's the best thing that we can do, to sort of alleviate the conditions. And then those people who maybe have things like EDS and more serious conditions that need appropriate medical treatment, then they can go to the specialist centers and get the treatment that they need as well.
I can just add a little comment to that as well. I couldn't agree more with those comments. And this idea that digestive well-being is sort of a lifestyle, set of conditions, I think is, totally misguided and fallacious. People who have chronic daily abdominal pain, nausea, diarrhea, or for that matter, have somatization disorder, fibromyalgia, chronic fatigue syndrome, daily chronic conditions where it feels as if to these patients, like they weren't even born for this world. Like they were inherited a body that isn't designed for this world. And what could be more, difficult and frustrating than to live like that? And so many years ago, we published a paper looking at suicidality among people with chronic abdominal complaints. And the literature is fairly evolved that people do, unfortunately and tragically, have, suicidal ideations. with IBS. And so when you look at it through that lens, this is no longer some kind of lifestyle problem, right? This is a chronic, serious illness that every study that we've seen massively impacts health-related quality of life. The HRQOL scores are on par with people with chronic kidney disease, and that goes all the way back to Ian Graunik's work from the late 1990s. And so to this day, I am absolutely stymied when I hear a colleague like I had when I was at the FDA panel once many years ago, cardiologists trying to explain to us that there's no way we can risk any, potential QT prolongation in a patient with IBS because IBS doesn't kill people. And that was a whole other discussion. But the point is, we still need to educate to this day on what it's like as best as we can explain it without having to, unless you feel it yourself, to live with this condition and the group of conditions that are associated with irritable bowel syndrome. The comorbidities are profound. So I just wanted to, make that point here as well. I think probably we all agree in one form or another, but it bears repeating sometimes.
Oh, completely. It's almost exclusively the reason I asked. I've said this before. This is a truly disenfranchised, but just as empowered patient population in many circumstances. Their quality of life is really diminished, and they're disenfranchised about that, but they're empowered to find solutions, and they're actively seeking them out. And I think, Dr. Hobson, the point that you made is a phenomenal one. In certain circumstances, if you have a case that, a patient presents 25-year-old female complaining of abdominal pain, but is absent alarm signs altogether, doesn't have blood in the stool, isn't significant weight loss, to just rule out altogether anything functional, scope that patient, come back, negative results, and move on and just say it's in your head, or go talk to someone else, that patient is going to feel discarded and disregarded, and many times they do. So it's partially the reason I asked. I think it's important for practitioners to hopefully not be doing that in the future, and anything we can do to embed an alternative concept into the early training of these GI fellows, I think is important. So maybe Dr. Shin, same question to you. Any insights you might have in this area?
Yeah, no, I completely agree. I think that, as a community and as a society, we do need to do a better job of role modeling what is, the appropriate approach to patients who struggle with chronic functional disorders. I do think that the training in general is very lacking. And it is a challenging area to work in. But, I recall, when I was a student, even learning about, conditions like depression, and being told that one of the easiest ways you can tell that someone is depressed is that when you are around them, you start to feel depressed, or you actually feel some of those symptoms, affecting your own mood. And in a similar way, with patients who struggle with chronic disorders of gut dysfunction, I think it's very common for clinicians to feel frustrated with those interactions, because oftentimes the therapeutic approach isn't straightforward. There's a lot of complex issues at play, but part of that is probably also mirrored in the fact that it is the patient who feels so frustrated. And instead of, trying to push ourselves away from that interaction, we should, accept that as the reality of what their experience is, and, try to be more engaged and involved in understanding, how can we better treat our patients without alienating them. And I think overall, if that can be more rewarding for them, it's more rewarding for us as healthcare providers. And if you become better at doing something, you start to appreciate it more. And I think the more that we try to avoid it, either during our training or even, as once we're out in practice, it just feeds into that cycle of stigmatizing this field of disorders.
Completely. No, I really appreciate that viewpoint. Just to quickly reinforce, and then Dr. Karsan, I'll give it to you to round things out. I am having discussions with GI clinicians, practitioners around the country and world, every day. And what I've heard many of them say is that some of the best success they've had with these functional DGBI patients is when they hear them say, you know, I'm frustrated. You're the fourth or fifth specialist or doctor that I've come to see, or I've been on this drug for 5 years, or these 3 drugs for the last 2, or, you know, whatever the story is. When the practitioner just is candid and transparent in response and says, look, you know, we've run this set of diagnostic tests, or we've gone through, you know, this set of workup, and, you know, I'm just as frustrated. I am not totally sure exactly what the root cause is, but we're going to work on this together. And ultimately they're able to, you know, find common ground and work toward a meaningful diagnosis, or at least a meaningful plan to manage whatever that set of symptoms is that patient is experiencing. And at a bare minimum, that patient doesn't feel discarded or disregarded. And I think, you know, that in and of itself is pretty important. Dr. Karsan, over to you.
Yeah,
Any final thoughts?
I just have to agree with pretty much what people have said here. And I think we have to realize these patients are suffering. I mean, it may be a syndrome, but to patients themselves, it's a disease and they are suffering. And I think it starts with training. I remember that, you know, I actually trained with Lynn Chang at UCLA, and we had the clinic and she actually was able to spend an hour and a half with patients. And some of the, obviously her patients initially are going to be people that, you know, maybe did not do well with other physicians or other therapies, but they were complicated. And, you know, to really sit down and go over things with patients, I got to empathize. And you also just have to communicate with patients and then reassure them. And I think that's where a team approach with a dietitian that I think has been very helpful for me. And then, you know, there's limited testing you can do, like breath testing and so forth, which can certainly help and maybe point you in a certain direction. But you don't want to be ordering every test under the sun. So I think non-invasive testing is the key as well.
Thank you. Important, helpful. Dr. Spiegel, I'll turn it over to you. I know we have, you know, maybe 5 minutes or so left and want to be mindful of time, but maybe any closing remarks, comments that you have, general insights.
Well, I think I've said a lot already, and you know, what we're hearing here is there's a lot of advances in our understanding of IBS pathophysiology. We're seeing advances in the microbiome in particular as at least one mechanism, potentially along a causal pathway for the whatever underlying principal cause of IBS is, if there is one. Or is this really about segmenting a group of people, as we've also talked about today, that presents in a common fashion, but has a very wide variety, a dazzlingly wide variety of comorbidities and underlying potential mechanisms, both neuropsychological, mechanical, microbiome, you know, and so on. So, you know, we know that the GI tract can only present itself to us symptomatically in a few archetypal ways. It turns out there are only 8 ways that the GI tract produces symptoms. And this is research that we did for the NIH, for the NIH Promise, which is actually in our My GI Health app. You can measure your scores across those 8 components of GI health. So pretty much you have abdominal pain, or you have bloating, or you have diarrhea, or you have constipation, you know, or you have nausea, vomiting, or you have incontinence, and you're pretty much out of principal symptoms. So the point here is, you know, IBS, of course, attempts as best as it can to distinguish organic disease from, you know, traditional organic disease from what we have traditionally called functional disease. But we also know there's a whole wide variety of under or undiagnosed mechanisms. How often do we actually think about the mesentery and the anatomy of the mesenteric root, right? I mean, we talk about Ehlers-Danlos, but every organ system has evolved differentially in different people. I mean, just start with that. There's so many biomarkers that we could be focusing on to segment patients more precisely and start figuring out what the underlying etiology is that's driving their symptoms. And then ultimately, as we've been saying, you know, it's important to become equipped in the clinic, and not just with theory, but with a set of best practice treatments. We've talked today about exercise. We've talked and the rationale behind it. We've talked about diet. We've talked about specific types of exercise, you know, core exercise and Tai Chi and stretching, right? We've talked about psychological therapies and apps and virtual reality and CBT, right? There's almost always something else one could do. And without sort of just saying we're at a dead end, I'm sorry that you inherited this body that is causing you tremendous distress, but I'm out of ideas. That's definitely not acceptable. And if you're out of ideas, then let's find somebody who's got more ideas. That's kind of how this has to work. So those are my kind of concluding comments. I do see a couple comments in the chat, and maybe Craig, you want to kind of, I'm not sure where we are at time, but maybe I'll take this for the panel if you don't mind. There's a really good question here, which is how do you define a functional GI disorder? Like, what does that literally mean? And, there's been a lot of controversy and discussion over the years about what does that mean? Is that a good term? We've now pivoted to disorders of gut-brain interaction, which sort of is a more holistic understanding that the experiences of IBS, those symptoms I've just described, result from, in some cases, form and function abnormalities of the gastrointestinal tract, but also neuropsychological abnormalities in everything from the peripheral nervous system, autonomic nervous system, enteric nervous system, and central nervous system. There's abnormalities on every level. So I'm curious for any of our panelists, I won't say more because I do have my own definition of this. What is a functional GI disorder? What does that mean to you other than just, reciting the Rome list of FGIDs? Like, what does that literally mean?
Can I take that first?
Yeah, please.
When I set the functional gut clinic up in about 10 years ago, all the clinicians I work with said, "Are you crazy? Why would you call it functional? Functional just like is associated with people being crazy." I said, "No, I'm going to reclaim the F word. I think functional should be, a functional diagnosis should be, the first positive step in a pathway where people start to get treatment." So you said, okay, we've excluded, serious pathological mechanisms, but you have a functional disorder. So just like when you go to a car showroom, the car looks great, but if you drive it and it's terrible, you're not going to buy it. And your gut might look pristine when you do an endoscopy, but if you try and feed it and it doesn't function properly, then there's the problem. So for me, the first thing to establish is a functional diagnosis should be a positive thing. You say, okay, we've looked at everything. You've not got a stricture, you've not got an ulcer, you've not got Crohn's. We've ruled all that out. That's the easy stuff to treat. What we're going to do now is make that car motor better. So let's have a look at how your esophagus works. Let's see how your stomach works. Let's see what the bowel is doing. So I think, you've got to reclaim the F word is what I would say is a positive diagnosis that you can then work on. That would be my take on it.
Any other thoughts about what is an FGID?
Yeah, no, I completely agree with framing it as a positive diagnosis because clearly people present with symptoms and we have the ability to look for other conditions that can present similarly. And once those basic tests come back and reassure us, we can, at that point have that discussion with the patient that this is actually a disorder, a diagnosed disorder, not and shouldn't be categorized as or defined as there's nothing wrong. There is something wrong in terms of how the gut is operating, and this is manifesting in terms of the symptoms or food intolerances or whatever presenting complaint may have. It may have been the reason they found their way to your clinic. But there's a wide array of different types of functional disorders in terms of how we might conceptualize them based on their predominant symptoms, but that's the general overview of how we would define or identify them.
And if you don't mind, Craig, maybe I'll just do this one other. Dr. Karsan, were you going to say something?
I was just going to agree with Dr. Shin. It's a constellation of symptoms, and you just want to reassure the patients. A lot of times, they just want to make sure they don't have cancer. They're like, "Do I have cancer?" No, you don't. This is not going to lead to cancer, but we can help you.
Right. And so maybe I know we're a bit over time, but let's just finish up here if you don't mind. A nice question here from Adrian. An established protocol for IBS would be really helpful, super helpful within primary care to better understand underlying need for further GI workup, as well as the greater addition of dietitians, which is severely lacking in primary care and even GI practices. And so I'm sure we all have our own kind of approaches. I would just say that the latest ACG guidelines on irritable bowel syndrome do provide excellent guidance. I wouldn't necessarily call it a protocol, but it's a pretty good sort of checklist of things to look for. Although some of the things we're talking about today, like looking for joint hypermobility, and I'm sure we all have our own version of some other example of that we don't always do. I think it would be useful to have a checklist. Like, for example, does the patient have kyphosis or scoliosis? What does their core strength look like? Some people kind of roll their eyes at this sort of thing, like, oh, that's what chiropractors do, right? No, sorry, you're missing the boat big time if you're not thinking about the actual mechanics of the way the body is set up, right? That doesn't mean we're going to pretend like this isn't neuropsychologically important too, that it's just a mechanical condition, but we need to think about these things too. So I do think that protocols around that would be useful in addition to dietary dietitians for sure. Oh yeah, Craig mentioned what DGBI is. Any of you guys follow any particular protocols for IBS?
Can I just say that, I think what we talked about with the apps and what you've got with My Total Health, it's an amazing opportunity to collect a constellation of symptoms and then develop outcomes and then put all that data back into the system so that when people put in that constellation of symptoms and medical history, you can then start to predict with more accuracy which pathway they should go down. So I think that is where the future is going. And the established protocol there at the moment that is fairly poor, and you've got two camps as well. You've got the people who've got more of a kind of Rome Foundation approach to it, and then you've got some of the microbiome people, and there's a little bit of tension. But I think there's no need for that tension because we're all batting on the same team. So I think collecting that data, but also collecting outcomes data. These people presented with symptoms, with this history. What happened to them? What treatment did they get? How did they do? And then feeding all that back into the algorithm is the thing that's going to help us establish a proper protocol that's apolitical and based on data rather than opinion.
Right. Well, Craig, should we wrap this up?
I was going to say, I think that's a perfect place to do so. We can turn it over to Jason, our CDI host, and I would just say thank you one last time to you, Dr. Spiegel, to all of our panelists. I think this was a really, really insightful conversation. I'm really appreciative of it.
Absolutely. We definitely appreciate everyone's time, our audience participation, for sending in questions today and during registration process. Thank you to our esteemed panelists, Dr. Hobson, for joining us so late in your day or evening, I should say. Dr. Shin, Dr. Karsan, as well as our moderators, Dr. Spiegel, Craig Strasnick from CDI and My Total Health. Again, on behalf of everyone here, thanks to our attendees for signing in, for listening, and be sure to check your email and follow us on social media for more GI community news and insights. We are constantly posting using hashtag GI community, GI Twitter. Follow the conversation, join all of our expert panelists online, social media, and stay in tune with what's going on in the community. Again, thanks everyone. Have a great evening, and we will see you online.
Bye, everyone.
Bye. Thank you.
Thank you very much.